So today
This meeting is being recorded.
Today we are going to be doing the shorter PowerPoint, okay? I see everybody has their name up good because I want you to get credit for being here. And I want you to know Dean Brown looks at that. So making sure your names are there is just to get the recognition for taking your time, because you guys are busy and I know you are. I mean, I know I'm busy just getting courses and things ready for you. So you have to learn them all. I'm supposed to know them all already, right? Yeah, I actually pretty much do. If I don't, I study too to make sure you get the right information. Believe it or not, I still have to go back and look. You can't know everything about everything. Okay, so this is week 7 through 9. Most of you have had lecture already. Some of you have your lecture on Friday. But basically, this is those weeks. So let's start out with the endocrine system. When you think of endocrine, we always think of diabetes. We think of blood sugars, and we think of the pancreas, and we think about the body digesting food in a way so that we can absorb it and eat it. Now, diabetes mellitus is type 1 and 2, but in children, 98% of the time, unless they're overweight adolescents, are type 1. And once you're type 1 diabetic, guess what? You're always type 1 diabetic. What happens is the body, it's an autoimmune condition where it attacks the pancreas and it's unable to secrete enough insulin to absorb sugar. So what would you see in a child that is going to be a newly diagnosed diabetic child? Well, these kids are going to be hungry as hungry. Because remember, the body is not absorbing insulin. It doesn't have insulin, so it can't absorb sugar. So the body's hungry still, right? So you're eating. Another thing is polyuria. You're urinating a lot and drinking a lot. But these kids are losing weight. And actually, it's the losing weight that usually brings them into the doctor's office. I've, had many young children, 2, 3 years old, newly diagnosed diabetic. And the reason why they went to the doctor was weight loss. Now, look at diabetes, it's 3 Ps, all right? Because we have another diagnosis that's only 2, and it's 2 of these. So be careful. Remember, if you don't have sugar, you're hungry. You're going to eat it. Polyphagia. Some of these kids also will have, accidents urinating in bed at night, enuresis, nocturia. They just can't hold it. Now, if you had an adolescent that came into the doctor's office and they had a BMI of 92%, which means this is how big they are, body mass index. That means weight to height, is a proportion. Well, the lower the number is actually the better. 92% is almost to the point of being obese. So they're complaining they're urinating more than usual. So what would you do to check that child? Well, because they are urinating a lot, well, electrolytes, because you always lose potassium, but urinalysis, because, maybe it's urinary tract infection. But it also brings to mind they're overweight, urinating a lot is part of the PPPs there, right? So they're going to do a hemoglobin A1C. So that's some sort of thing that you're applying your knowledge to diabetes. This is another picture you can look at. It says what I'm talking about. So diabetes mellitus type 1 is 3 Ps. It's that weight loss, and they start becoming fatigued, and they start getting nausea and vomiting and getting dehydrated. When that happens, you're going to start to see what we call ketoacidosis, right? Now, diabetes and hyperglycemia. Your blood sugar is way too high. Now, there's a difference between hyperglycemia and DKA, or diabetic ketoacidosis. Hyperglycemia is just an elevated blood sugar. It doesn't mean that your body's starting to eat other places for food. It just means your blood sugar is elevated. But DKA is when it's to the point where the body is hungry. I keep saying this, the body's hungry. There's sugar, but there's no insulin to be able to digest it and use it in the body. So what does this body say? Well, if I can't eat sugar, what else can I eat? And it starts going to proteins and fats. And the byproduct of these digestion is ketones. That's how you get the ketones from digesting other stores of food, which is protein and fats. What are you going to see? Well, when it gets to the point where your body's doing that because you can't use sugar, so you have elevated blood sugars. The highest I saw was 1108, I believe the number was. Can you imagine? 1108 was a blood sugar. Now, ketones are going to be spilled. So you're going to see ketonuria, okay? And you're also going to have this smell coming out of your breath. All that sugar, you're going to be breathing sugar. That's why you get that fruity smell there. And because of all of this, you're going to get drowsy, you're going to poor skin sugar, they're pale. These kids can't even lift their head up. That's what DKA looks like when they come into the emergency room. And if it continues, it goes hypotension and bradycardia. So DKA, elevated blood sugars, I can't use it. Body said, I'm hungry. Let's go get some proteins or fats. The byproduct is ketones. So you're going to start seeing those ketones in the urine. And then, of course, it goes into the blood sugars. Actually, that child with 1108 had a 6.89 pH. The kid made it, okay? Barely made it. He was that ill. Now, let's go to the opposite extreme. You're hypoglycemic. Sometimes it's because a child took insulin and didn't eat. Many times in the hospital is, you've given the coverage for the morning blood sugar and you didn't get the lunch tray there or the breakfast tray there quick enough. So now they become hypoglycemic. Well, how would you know that's happening? Well, it's the signs and symptoms. You're going to, of course, the sweaty, the jittery, the dizzy. Those are the big things. And then they're nauseous and you could even start vomiting. So what do you do if a kid is hypoglycemic? Well, patient condition. Are they awake and alert? Are they talking to you? Or are they unconscious? Because they could be either or. Now, if they are alert, talking to you, they can eat or drink. Give them some sugar. Sometimes it's orange juice. Sometimes it's milk. They even say graham crackers and milk. I mean, something, give them something to get their blood sugar up. If all you have is some lifesavers on hand, give them 5 or 6 of them. Get that blood sugar up too. You're in a restaurant, they didn't feed you yet, get a sugar packet, put it in your mouth. I mean, these are things that are a quick fix for hypoglycemia. Again, nice little mnemonic for you. He is tired, and it's a great mnemonic to show you all the signs of symptoms of hypoglycemia. All right, let's go start talking about the pituitary dysfunction, the pituitary gland. Well, pituitary gland has anterior and posterior lobes, okay? The anterior lobe has to do with growth, okay? It also has to do with, is the kid growing well enough? And this is why, one of the reasons why we do height and weight on every visit. Whether they're going to an ER, doctor's office, doesn't matter. They always do height and weight. Are they growing good enough? And the other lobe has to do with what we call urine. Urine function. Do we hold it or do we release it? So we're going to go into what those two things mean. So, and remember, both are different. Just because it's pituitary, the posterior has nothing to do with growth and the anterior has nothing to do with urine. So those are the two lobes. Now, hyperpituitarism, too much growth, means these kids are going to get really big and tall. It's called gigantism. This is usually due to a pituitary tumor most of the time, and they'll just remove the pituitary gland, right? And then they have to give growth hormones if they're not growing the way they should to replace those. And then hypopituitarism, this is a child who's very, very small. Sometimes it's the dwarfs, dwarfism could be part of that. But what this kid's a normal kid, and everybody in their family is tall. Mom is 5'8", dad is 6'2". The kid should be taller, but the kid's too short. Well, we can give pituitary hormones. We give what we call growth hormones. Now, growth hormones are usually daily. They're subcutaneous. It'd be like giving an insulin injection every day. So these children would have to either themselves give them subcutaneous injections every day or the parents. So it really takes a commitment by the parents. And they'll continue this hormone until they stop growing. They're growing less than 1 inch a year, they stop it because the kid's not going to grow anymore. So hypopituitarism, again, it has to do with not enough. We're going to be giving that sub-Q injection every day, and we'll be monitoring that a lot. And again, looking for what other pathological reason. Now, remember, make sure before we do growth hormone, if the whole family's really short, you can't get a kid taller than what they're supposed to be. And that's a great question to ask. So how is everybody in the family? Are they tall or are they short? Now, precocious puberty is what we call the development of secondary sex characteristics at an earlier age than normal. You will see 6-year-old girls getting their period. You'll see them already with having the breast buds, go through all those Tanner stages of development. Even boys, you'll see them hair on their face and beards and whatnot. And we can give medication to stop it to the point where they should be going through puberty. And we know it's 10 in girls and 12 in boys. That's the number. Now, let's talk about the other lobe, the posterior lobe of the pituitary gland. There is diabetes insipidus, and there's syndrome of inappropriate antidiuretic hormone. I'll say that 3 times quick, right? Let's call it SIADH, please. All right, diabetes insipidus is only 2 P's. Remember, the pituitary gland has to do with urine function, holding it or giving too much. So you either urinate a lot or you don't urinate enough when there's an issue, but it does function how much you're supposed to. In diabetes insipidus, you drink a lot and urinate a lot. And remember, it has a lot to do with urinating a lot. Remember that always you worry about electrolyte problems. They do get rid of potassium. So we're worried about dehydration. What do we worry about dehydration? Elevated heart rate, low blood pressure, poor skin turgor, prolonged capillary refill, decreased urinary output. That's not going to happen, right? Because this kid's still going to be urinating. So that's the difference with diabetes insipidus. But dehydration, or all the other symptoms we're going to see there. So we give vasopressin, and that you'll know it's working when the urinary output starts to decrease. Now, SIADH is when the body secretes too much anti-diuretic. So it's against urinating hormone. And that's the way I remember it. Anti-diuretic against urinating hormone, which means you're holding on to urine. So what happens? Well, the fluid goes somewhere. So this child's going to be swollen and an edematous. And these children, you're going to have to be watching intake, output, and we're going to be monitoring daily weights again, because we could see if we've lost fluid or if we're gaining fluids. So diabetes insipidus, polyuria, polydipsia. The interesting thing about infants, sometimes it's hard to diagnose. The kid's just crying, they're hungry all the time. And it could be just this kid's just hungry all the time. But if we give them a bottle of water and they stop crying, then we know to go and look for diabetes insipidus because it satisfies them, believe it or not. So with diabetes insipidus, you can stop giving them fluids. It's not going to make any difference. They're still going to keep urinating. And those are things that we look at. So remember, diabetes insipidus has nothing to do with blood sugar. This is a big misnomer. I can't tell you how many nurses in the triage area see diabetes insipidus on a history and do a blood sugar and come in and say, oh, the blood sugar was 99, it was okay. And I'm like, okay, it has nothing to do with diabetes insipidus. Now, I'm not going to do that in front of family. I'm not going to do that in front of anybody. But later on, I'll go, it only has to do with fluid balance. So our biggest thing here is an accurate weight on these children. Okay, so diabetes insipidus, we need to replace the hormone, and we give vasopressin, and it is treatment for life. As a nurse, our responsibility, remember, fluid balance, urine, daily weights, intake, output. We can see, is the medication working? Is it slowing down? SIADH is a big soaked person, right? This big, just full of water here. So how do we manage it? Again, it's fluid balance, intake, output, daily weights. And remember, this could go into their lungs and it could be congestive failure. So watching out for those things are important, especially if there's other conditions associated, that this child has. With SIADH, we do a water restriction and we put them on that low sodium diet. We don't do that with insipidus. We don't hold fluid because it does nothing, okay? Because of retaining all this fluid and retains a lot of the electrolytes, you're on seizure precautions for these children. And these children will be put on drugs that suppress the vasopressin so that we can start releasing the urine on these kids. Again, intake and output. And here it is, put side to side, looking at what you're seeing, okay? It's the hyponatremia that causes the seizures here. How do we know medications are working? Well, diabetes, we're not urinating as much. And SIADH, they're starting to urinate, their weight's going down. Another hormone we think about is, in the endocrine system, is thyroid. Now, a lot of things are exactly just like adults. When you talk about thyroid hormone, too much, too little, in adults or children, you see a lot of things. The only difference is growth. You need thyroid hormone for growth. And if it's a hypothyroid child born with hypothyroid, it needs thyroid replacement hormones because of cognition. So those are the two. The difference is cognition. You need it, those hormones, to be alert and be able to grow right, for growth and development, and also you need the hormone to grow, to be a normal height and weight. Now, hyperthyroidism is also called Graves' disease. And this is usually that pre-adolescent area, that 12 to 14 years. Now, too much thyroid can produce a lot of symptoms similar to this thyroid storm. All of a sudden, your heart rate speeds up, you run a high temperature, you get chest pain. It is a horrible, horrible feeling that needs medical attention right away. Now, it could be to the point of the extreme, which is the thyroid storm, or it could just be too much hormone. So what do? We give medications to block the hormones from being overproduced because we don't want to get to the level of thyroid storm. So we give a lot of medications. It's probably Pripacil. It's also called PTU, okay? That's an easier name for me. So if they're given PTU, we need to tell and teach the child and the family what are side effects of this. Now, it's leukopenia, but leukopenia is something of a low white count and you're more susceptible to infections. Usually they say fever and sore throats. So we can't assume a child just is sick that has a fever and a sore throat. If a child is showing these symptoms, we need to call the doctor, let the doctor know. That's what we tell our parents. If it's a leukopenia, which is due to the PTU, the Pripacil, we're going to treat it with glucocorticoids, which means we're going to give steroids for it, okay? Now, the only other thing we can do for hyperthyroidism, if it continues to be overproducing thyroid hormones and continuing to give problems, we're just going to eradicate it with radioactive iodine, which means we get rid of that thyroid. They will be on replacements for life. Now, what do you see with hypothyroidism? Well, if a child at birth, one of the things we see is constipation. That's one of the things we'll check if there's no stool in the first 24 to 36 hours. That's another one that we talked about, Hirschsprung's, right? something that if we don't see a stool is something we'll be looking for. But what do we see as a child is growing with congenital hypothyroidism? Remember I told you we need thyroid hormone to grow, right? So this kid's going to be littler, shorter. It's not going to be on the same level as other children. Their skin is going to be dry and they got these puffy eyes. Now their hair is going to be sparse and it's, dry scalp too. They're going to continue with their constipation throughout life, something that needs to be monitored closely. And because everything's down, you have mental decline, remember cognition, and sleepiness. And these are signs and symptoms of a child to look out for who has thyroid hormone dysfunction. I mean, you talk about adults, you'll see also the cold intolerance and that. And these kids, they all have all of that. But our biggest thing is mental, cognition, and growth. So here's the difference between both of them. So hypothyroid, how many women say, well, I must have a hypothyroid. That's why I'm a little overweight, right? But they gain weight on it. And then the hyperthyroid, because your heart rate's more elevated, you're more up, up, up. Again, that's a weight loss. All right, let's go into another adrenal gland called the adrenal gland, another hormone, right? So the adrenal gland produces cortisol and aldosterone. It's just part of what they do. There is sometimes where we could go into Cushing syndrome. This is usually when we take prednisone, high doses for long periods of time with certain diagnoses. What do you see with Cushing syndrome? Now, Cushing syndrome, you're going to have that big round moon face. You're going to have those red ruddy cheeks, as they call it, but the big protruding abdomen with striae on it, but the arms and the legs are skinny. That's the difference. Those arms and legs will be very skinny. You're going to see hair growth. You're going to see acne. These are all part of the signs of too much cortisol in the body, which could be, as I said, from exogenous, which is like prednisone. Another picture for you: hair growth, moon face, red cheeks, weight gain, puffy, fatty areas on the face and trunk, that big abdomen. Again, too much steroids, it's that poor wound healing, right? And of course, ecchymotic areas. And as I said, those thin arms and thin legs are part of it. Now, adrenal glands do secrete, this cortisol and aldosterone, and it is used for actually sex assignment as the child's intrauteral. Now, I have seen only one in my career, and I just didn't know what to do with it. I didn't understand. Of course, I went and I started looking. Well, what happened was this child, well, I think they ended up making the child a female. They had a vagina and they had testicles. But you can see like a prominent clitoris and a vagina, which sort of looks like a penis and a vagina. It can be all different mixes up. So what do we do at birth? Well, we can't say if it's a boy or a girl because we have to assign the sex. So they're going to be needing, cortisone for life and aldosterone for life. And those times where they are in stress, they're going to need replacements. It does affect their hormone levels. And they're going to have to do some sort of surgical repair to make the child's genitals look, whether it's a female or a male, okay? So this can be very confusing at birth. Can you imagine if you had a child who had ambiguous genitalia? So did you have a boy or a girl? And you go, I don't know. Can you imagine what support that nurse has to give this mother for sure? Now, a neurological problem, neurological exams, and what do you see when there's something's going on with the head? Well, number one, you need to do a good neurological exam, looking at their movement, their strengths, their eyes, all of these, the cranial nerves. It's all part of it. Now, what are things that can affect cerebral function? Well, many times we have to, according to what's happening, like meningitis or suspected, we might have to do a lumbar puncture. And that does take some fluid away. And we know that we have to treat that child and keep them flat for a while and not lift them up too quickly because they do get really severe headaches, just like spinal anesthesia. Head injuries, meningitis, like I said, cerebral edema. It could be from an injury, a fall. There's all pressure going on there. Hydrocephalus. I mean, the fluid is not going up and down the cerebral spinal column the way it should, and it collects in the brain, and the kid gets bigger, bigger, bigger heads, right? And with all of that, you can have seizures. Now, what is a seizure? Well, a seizure could be it's a problem where something in the brain has, like I call, a short circuit, and it just goes bzz, and the body reacts to it. It's a very simple way to describe it. Something sparks in there. And then all of a sudden you will see it manifest with maybe, a blank stare, or it could be to the point where it's tonic-clonic, which is all of the extremities are moving in it. Now, these seizures sometimes are once in a lifetime, or sometimes it's going to be long-term. Now, epilepsy is characterized by 2 or more unprovoked seizures with about 24 hours apart or less. So it's more frequent. So we know something's going on. I mean, one seizure event, they're not going to treat. They're not going to give anti-epileptic and things for. It's going to have to be that child who has more frequent, because we know febrile seizures can cause it, right? My oldest grandson, had one febrile seizure and never had another one. But the mother didn't go anywhere without a thermometer in her purse. And she checked that kid's temperature and carried Tylenol, Motrin wherever she went. So I think she checked temperature 4 or 5 times a day, if I'm not mistaken. She was always, doing one of those ear temperatures. Anyway, what causes a seizure? Well, we know infections. I mean, what is, meningitis, right? There's an inflammation of the meninges, which covers the brain. It could be some sort of lesion or hemorrhage. Metabolic disorders can also cause it. Trauma. I mean, kids falling down, hitting their heads, and increased pressure causes it. There are a lot of different brain malformations, any genetic disorders. Sometimes of course, kids drink and eat everything, right? So it could be a toxic ingestion. And of course, we know seizure. A fever can cause it. I've heard a couple different things on some of the discussion questions regarding fever. Now, a febrile seizure is because they've gone from no fever to a fever in about 20 minutes. So you have none and it sparks up quick. And the brain gets a spark like what's going on here, and it creates a seizure. Usually that's 6 months to 6 years old, and they usually grow out of it. Okay, that's febrile seizure. Now, sometimes, we have seizures in the hospital, and you're going to be walking into a room, and these kids, maybe they're known to have it, or maybe they're having one of those febrile seizures. How do you treat that child? Well, we know we can't do much because they're going to be usually tonic-clonic is what we think of with a seizure. That's going to need some sort of intervention. But what we can do is turn that kid over to the side. If they're going to vomit, they vomit out that way. Also, make sure there's nothing in the bed that they can bang on that's sharp edges. So everything in the bed, let me tell you, I just take and just throw it on the floor. I'm also going to remove the pillow, and I'm going to put them, the bed flat. And if I can, pad the side rails with pillows or blankets or whatever I have. And also, I'm going to yell for help, of course, medical team in there, because who knows how long it's going to be there. This is something we need to teach our parents also. How do you keep your kids safe? Remember, nothing in the mouth because they're clamped down. You don't want to break teeth. So I was mentioning tonic-clonic. This used to be called grand mal. There used to be petite mal and grand mal. Well, now they've renamed them. There's partial seizures, which are could be those little absent look at, or maybe just a twitch on a shoulder or one arm. Tonic-clonic is all of it, everything. And usually when we say tonic-clonic, it's that moving from flexion to extension, posturing in the seizure. They do have a level of consciousness, they'll lose it, okay? And they'll be jerking and foaming at the mouth. That is the most common one that we think of when we think of seizures. Now, cerebral palsy. There's all different types of cerebral palsy, okay? But when we think of cerebral palsy, I mean, I think of my poor little Jonathan. I need to go visit this kid. He's from one of those special needs daycare, prescribed pediatric daycare with CP that I used to do clinicals at. My little guy, absolutely spastic. He would look at me and his arms would come up and he'd be like this really spastic movement that he couldn't control. So spastic, they have a poor control of posture, difficulty maintaining balance, and hypertonicity, it's called. And these children, remember, they're born with it usually, or something's happened right at birth that would cause these sort of things. Now, head injury. You know, there's all different ways that kids get head injuries. You know, I have mentioned in my class, motor vehicles, you know, we think of inside the car, but remember kids are ran over by cars. And it's usually the aunt, the uncle, the next door neighbor, mother or father. And I've seen good outcomes and I've seen not good outcomes. So that's, you know, they could even, you know, run over their head. And I've seen that also. Also, you know, kids, bicycles, and sports are big things that can cause head injuries. Now, we know that at the time of the injury, you don't always see exactly what's going on because the swelling or the bleeding that's in there is going to accumulate over time. So as you have a child admitted under your watch with a head injury, because you're going to be watching those neuroscience, those level of consciousness, seeing how they're doing. If all of a sudden their level of consciousness is changing, they don't remember where they are. If it was that kid who came in with a sports injury that slid in and, you know, hit somebody's knee and, you know, they're just confused. And they're all of a sudden, now they don't even know that they were playing baseball. I mean, something's going on, okay? Another thing, if they're vomiting a lot, like more than 3 times, absolutely, that's something, there's increased pressure that's going on there. If their eyes, their pupils, they're sluggish, they're not as briskly reactive to light, something's going on there. And if they're getting up and stumbling over or not walking correct, these are all signs, symptoms of an increasing problem with swelling in the brain and increasing head injury going on. And that headache, it's so bad, it wakes them up from sleep. That's another thing that we also see too. So what are you monitoring? Well, I've just mentioned all of them. Let's do them again. Change in the level of consciousness, or the way they're acting. They're restless. Restlessness is a big one. Difficulty to arouse, vomiting more than 3 times, pupillary changes, doubled or blurred vision, trouble walking, that headache that wakes them up. And then this one here, the most important of all things that we need to be a lookout for. Fixed dilated pupil is a neurological emergency, and it's usually 1. You will see physicians notoriously. I've had a child, more than 1, fall off a 2nd floor balcony onto their heads, you know, on the ground. The first thing the physician does is look at the pupils. Are they already fixed and dilated? Does this kid need to go to the OR now to get that bleeding under control by the neurosurgeon? So, neurological emergency. Spinal cord injuries, our priority is to keep that spine immobilized. I was telling my class about a 16-year-old that came in. He literally slid into third base and his head hit a knee and the crowds heard a crack and immediately he had weakness in his lower extremities. They had someone there who kept them immobile. They got him by helicopter, rescued to us, and I was the primary nurse on. And my job was to keep that neck straight. It was an angulated C5, C6 fracture, severe. And by the time he got to me, not only was his right leg numb, the left leg, he could barely feel it also. The outcome to that, he did get an MRI from the ER. Very unusual, but that's how severe he was. The outcome 2 weeks later, he had feeling in both legs, some slight numbness in one side, and that kid was going to rehab for physical therapy, but he did well. I saw him a year later, actually. He came to the ER to find me. So nursing can make a difference between having a child or an adult paralyzed. So meningitis, well, we know the meninges covers the brain and the spinal cord. And the meninges can have an infection. It could be only viral, which we just treat with Motrin, Tylenol, and just rest and fluids. It's just there's no antibiotics that we do for that because it's virus. But there can be really bad bacterial type of infections. So this is the kid that's going to be complaining of a severe headache. They can get to the point of those stiff necks, the photophobia. And these kids, if they are infants, we can see the fontanelles are bulged. I mean, if they're older, they're going to be complaining of that headache and that nausea and the vomiting. And this opisthotonus is that severe neck stiffness resulting in that arched back. We know if they pick their legs up, their head comes up, all these things. And remember, you suspect meningitis, get prepared. You're going to be doing a spinal tap for sure, right? Because that cerebral spinal fluid is going to tell us, is it viral? Is it bacterial? If it's viral, it's going to be clear fluids. And if it is bacterial, you're going to see almost like milk. What you see in a child in this spinal tap of a child with a bacterial infection, you're going to see white count. It's going to be really, really elevated. It could be too numerous to count. I mean, that's going to look like white cream almost, that cerebrospinal fluid. But it's low glucose and elevated protein. Those are things you would see. Remember, anytime we do cerebrospinal fluids, treat this child like they're getting like that spinal anesthesia. Keep them flat, get fluids in them, and slowly elevate the heads of their bed because they will get that spinal headache, and they do hurt. So your kid, yes, it's that white milky spinal tap. Yes, these kids will definitely be admitted, and they're going to be requiring IV fluids and antibiotics. Put them in a quiet room, no TV, no lights, hopefully in an area where they don't hear all this noise going on all over the place. Now, how are we going to be treating these children? Well, your priority in meningitis is those IV antibiotics, okay? Priority antibiotics. Now, sometimes, that kid fell down off the second story, has been admitted, and we're watching the child closely. One of the things that can occur because of all this damage is cerebral edema. Now, sometimes it gets so much fluid in the head that it's compressing the brain and all the body functions of the head. So we need to get fluid out quickly. So we need a diuretic. Now, only for the head, mannitol. Remember, mannitol is the white crystals in it that we don't give it. It's given through a filter, but this is specific for brains. It's not furosemide, okay? It is mannitol. And you will see an increased fluid being diuresed, and you're going to see the intracranial pressure come down really close. So in cerebral edema, what is our big thing? Well, it's fluid balance again, guys. So what do we worry about? Intake, output, and if we're able to, daily weights. Many of these beds have scales on them today, and we can weigh them. With meningitis that's bacterial, these kids need to be in isolation for 24 hours, which means they need 24 hours of antibiotics before they can be taken off antibiotics, okay? And remember, these kids, their head hurts, their eyes hurt, they don't want to talk. So minimal stimulation and what we call cluster care. Go in, do everything at once and get out. Leave them alone, okay? That is basically the best care that we can give to them. So again, when we're seeing increased intracranial pressure, what are we monitoring? Again, level of consciousness. Are they lethargic, headaches, vomiting, okay? And remember, infants, they're easy to tell any extra fluid in the head because of those fontanelles. Because we're gonna have one up till about 12 to 18 months, right? There's gonna be a fontanelle somewhere that we can check. And it's gonna be bulging when they are at sleep. You know, sitting up at sleep is bulging. You're like, there's a problem. So we can treat it pretty quick. Okay, another problem that can occur in children is what we call myelomeningocele. A myelomeningocele is one of the 3 different things that we've been taught that the body doesn't get it inside by the time they're born. We have the stomach, gastroschisis, born on the outside. We have bladder exstrophy. The bladder is born on the outside of the low abdomen. And we have a myelomeningocele, which is the spinal cord and meninges are born on the outside of the lumbar spine. What do we need to do immediately? What is our goal? Well, we want to prevent infections and we want to keep that tissue moist. So we're going to put a normal saline. Okay, that's the first thing they're going to ask for. Give me some normal saline, put it on sterile gauze, and we're going to put it and cover it, protect them from infection and keeping that tissue ready. So when neurosurgery is ready to put it back in, we can, okay? Now, one of the things with myelomeningocele, now we've treated it, it's covered up well, we know the tissue is going to be preserved, we're looking out for infection. Now our goal is, because those nerves and spinal cord sort of were ripped out to go pulled up, some of those nerves are ripped, the bladder function and the bowel function could be interrupted. It may not be nerves there. Those nerves might have been ripped, okay? They might have been torn. So they're not going to have feeling. Sometimes they have a little feeling in their lower extremities, sometimes none. But our concern is urinary function and bladder function. Some children will require every 4-hour urine catheterizations, and we need to monitor bowel function. How often are they taking a stool, and do we need to help the child move that? Now, sometimes with myelomeningocele, because of that spinal column and meninges, now we've interrupted it. Many of them end up with hydrocephalus and require a ventricular peritoneal shunt. One of the biggest diagnoses we use it for is the myelomeningocele. There's some children who just get hydrocephalus, but most of them is the myelomeningocele. And what it is just this little catheter that goes into the ventricle, the 4th ventricle of the brain, comes behind the ear, comes around the front and down the front of the belly into the peritoneal cavity, and it just leaks fluid. So it keeps that fluid moving so it doesn't build up in the head there, okay? Now, what is the big thing with VP shunts, and what do we need to teach our families and our child? Well, if we start seeing a child who's vomiting and has a headache, probably something's going on with the shunt. Remember, kids grow. Does that catheter, is it long enough or did it pull out? And now we need to do what we call a shunt revision, okay? So these things are great, they work well, but they need to be taught about the headaches and the vomiting. Now, once they come out from these surgeries, always put them on the unaffected side. And of course, we're going to be seeing, do they're still complaining of headaches? Are they nauseous and are they vomiting? All of those things very important. And, you know, sometimes you get these kids with surgery and they're young, and or some kids intubated and we don't know, are they in pain? Well, one of the things that we can tell, even on a paralyzed, sedated child intubated, you're going to say, well, they're not in pain. Well, what you're going to see is their heart rate goes up and you're going to see blood pressures go up. and and there's no extra noise in the room, there's nothing, that's when we know maybe they need something more. Now, Duchenne muscular dystrophy, this is like tetralogy of Fallot. You're always going to see this everywhere. You're going to see this on HESI, you're going to see this on NCLEX. Those are the two diagnoses you're guaranteed to see. So Duchenne muscular dystrophy is X-linked related. It comes from mom. And usually it's males, and we'll see it and diagnose it about 3 years old, up to about 7. This child will have some cognitive delays. That will be something that they're born with, but they're born, they'll be walking, and then all of a sudden they'll have these very hypertrophic calves, and they'll just all of a sudden start becoming weak. They'll start waddling to walk. They be falling a lot. And you know what Gower sign is? It's what I do every time I get off the floor. I crawl up my legs to stand up. That's Gower sign. Being the old ladies, I get off the floor like, oh, let me use those knees and let me get up. So they have that. They also, one of the things we learned about this week was different sort of spinal column, different angulations. Well, they have lordosis. The lower lumbar spine is like an inward, so they arch backwards, okay? So these children, as I said, are going to have some mental impairment because they can't move as well. They're going to have more weight on them. They're obese. And because it's a progressive muscle wasting, they usually die as a teenager from usually the phrenic nerve and the diaphragm stops working, or the heart. So respiratory or cardiac failure. Now, when we first starting to suspect this, they're going to do something called an electromyography, which is an EMG. And what it does, it gives a little spark of electricity. And you watch how the muscle contracts to it, and you're going to see it not retracting the way it should. Now, this hurts, so please let the parents know. And if the child's old enough that they know, and medicate them. I mean, Tylenol's good enough, but they need something when they come back. And remember, it's temporary, because the parents will go, well, the kid didn't hurt when it went down. Now he's saying, ouch, ouch, ouch. So let them know. When we do that examination and we see that weakness, then we're going to be giving them, therapies, physical therapy, making sure that we keep them moving. So EMG is done. They can have those muscle sores. And again, enlarged muscles, especially, the thighs. I even see that the calves are just really like profound. You can see quite large. And again, they are impaired. Now, near drowning or submersion, I live in South Florida, and I've seen a couple near drownings of submersion injuries. Now, many kids get to the bottom, somebody goes in, picks them up, and by the time rescue comes, they're running around. And you're like, oh, that's great, they're fine. Well, no, they're not. They have up to 72 hours later where they can start into a respiratory distress syndrome, okay? These children need to be admitted, and they need to be placed in some sort of monitored unit with an O2 sat monitor, because we're worried about oxygen saturations. Because what happened? Their lungs were full of water. They had a hypoxic episode, and that can cause them to go into respiratory failure. So priority, watching these children, respiratory. Now, GI things. All right, GI system, remember, children, dehydration is serious. Adults tolerate it well, kids do not. They go into total body failure, organs go. Dehydration in children needs to be treated immediately. Now, there's going to be on your HESI guaranteed questions regarding acid-base balance. So, if we're vomiting acid. So you're left with your alkaline. So you're left with metabolic alkalosis. If you're having diarrhea, all those enzymes are alkaline. So you're left with acid. So you have metabolic acidosis. That's how I remember things, okay? If you're getting rid of one, you're left with the other. Okay. So if a child is vomiting and they can't take anything by mouth, again, we're going to start an IV. Remember, it's very important to get a set of electrolytes. We want to know how severely dehydrated they are, okay? We only give normal saline. We never ever bolus with any electrolytes or dextrose. So how do we bolus? Normal saline. If they can take by mouth, we're going to give Pedialyte to the younger children, Gatorade, Powderade to the older children. So vomiting is when they're vomiting, they're nauseous. It could be just a gastritis, could be something they ate, one of those things. There's nothing, physiologic. That's the problem. We're going to go into that one later. Now, vomiting, remember, they're losing fluids. They're losing fluids. And if it comes to the point where you see a child is just getting lethargic, we know that kid needs replacement now. If they're vomiting, they need an IV started. And as I said, get that metabolic profile, start an IV bolus. Normal saline is awesome. No sugar, no electrolytes, and you keep them NPO until we can give some antiemetic and rest that stomach, and then we'll start it again. Now, projectile vomiting is different than just regular vomiting. Projectile vomiting, you can take that kid, point it at a garbage can 10 feet away, and the kid's going to vomit into it. That's how severe this projectile vomiting is on pyloric stenosis. That is the difference. Kid comes into the ER, the first question, if they're vomiting, is it dribble or is it coming way out? That's your first question, because now you know what it is. Put your hand underneath, right by the xiphoid process, a little to the right, sometimes a little in the middle. You're going to feel like a little, I call it a marble. They call it an olive. It's just a little round something. And what that is this is a thickened pyloric valve, which is on the lower edge of the stomach. And that stomach fills up with milk, fills up with milk, fills up with milk. They're fine. And then all of a sudden, the whole stomach contents forcefully, that's aiming it at the garbage can, because they will hit it. It's that much. So if we feel the little thing, they describe that vomiting like that, tell the parents, even grandma, because sometimes grandmas down here in Florida will tell everybody what to do, like me. No, I'm teasing, but many of them do say, we're not going to feed this child, this kid. We need to do ultrasound, and it could be this little sphincter going on there. So make them NPO, get them to the ultrasound. Once we diagnose, get that IV in. And sometimes we do the IV even before ultrasound if the kid looks very lethargic and looks like they're dehydrated. Now, diarrhea is different. If a kid is awake and alert and has diarrhea, it doesn't matter if they had it for 3 or 4 days. If they're able to drink, give them oral rehydration. Unless the patient condition is so bad and they're so dehydrated, then you'd start the IV, okay? So again, what are you going to monitor? Going to start an IV, or even if you don't, we're going to be doing electrolytes. How severe is this dehydration? First of all, it's physical assessment. Are they that pale? Where's the heart rate? Where's the blood pressure? How's the urine output? All of these things we're going to be looking at. It makes a difference. But vomiting, we're not going to feed a child who's vomiting any liquids. We're going to IV. Diarrhea, we're going to be giving them oral rehydration, electrolyte solution of some sort. And then start to introduce the diet slowly. Okay, dehydration. As I said, dehydration is pretty serious in children. Again, it could be due to many different reasons. It could be that gastroenteritis, the vomiting, the diarrhea, it could be burns, it could be so many different things. Remember, fever has a lot of insensible loss of fluid too. So a kid with a fever with vomiting is going to be even more susceptible to dehydration. Again, can't say it enough. IV normal saline, no sugar, no electrolytes. Get yourself a metabolic panel. See what's going on with it. And one of the rules of thumb is we don't ever add any potassium to any maintenance IV with an electrolyte until we see that the electrolytes from the lab or until the kid urinates, because we don't want to start kidney failure. Appendix. Appendicitis. Well, appendicitis, it's that right lower quadrant, McBurney point, all of that, just like adults. Now, what I'm concerned about is that appendix that already burst before they went to the OR. Now you have peritonitis. You have peritonitis, it's a really bad infection of the peritoneal cavity. So these children, as soon as they're admitted, and we've diagnosed with an ultrasound, it's an appendix, we're going to be starting an IV, and this kid is made nothing by mouth because the kid has to get to the OR. Now, if it's already burst, all of a sudden their pain stops. It's like they have this terrible pain, they're crying, and all of a sudden this kid's up and moving around, and you're like, uh-oh, this is burst. Post-operatively, what are we going to see, and how are we going to treat them? Well, the appendix burst and all the toxic fluid has entered the abdominal cavity. The intestines are angry. The peritoneal cavity is really angry. So these children will be maintained NPO. They'll have an NG tube because we want to put down, because we don't want any of gastric juices, anything, mucus, anything to go into the intestines because it's angry. It needs to be rested, okay? Now, when we take that surgery and close it up, remember the peritoneal cavity was infected. So we had to close up and make an incision line of infected tissue. Make sure you check that dressing, that incision line. It can dehiss, and I've seen it dehiss on a ruptured appendix. So make sure we look at that. IV antibiotics, priority, priority, priority. Make sure we give this child something for pain. They need to get up. They need to get out of bed. They need to prevent their lungs from filling up, incentive spirometry. They need to ambulate, and we need to prevent blood clots anywhere. So up, out of bed, and moving just like you would any person who's just had surgery. Now, reflux. Reflux is when the stomach flows back up into the esophagus, and it burns and it hurts. And older kids, they could have little mini aspirations of this, and you'll hear them cough. That's a telltale sign that, pain, the abdominal pain, heartburn-like, and that cough. We know that's GERD. Well, medical treatment. How would we treat an older child or even a younger child that we're seeing maybe the cough on the little infant, or maybe we're seeing a little bit of vomiting that's going on? Well, we're going to start with something like ranitidine, and today it's Pepcid. Okay, and what does that do? Well, it reduces stomach acid production. So it's less acid, less burn coming up, and it will hold it down. And diet is always key. If we have reflux on infants, we're just going to take a little bit of rice cereal, put it in the formula or put it in the breast milk and give it to them. It thickens the milk and it holds it down. As simple as that. There's no nutritional value, but it holds the milk down so they're getting more nutrition. Now, an older child who's been on Zantac, PPIs, been all sorts of Mylanta and all those different GI meds, and it's really not working, they might go for a surgical correction, and that is called a Nissen fundoplication. And what it does, it takes the top of the stomach and it folds it over so that these children can't get vomit coming up their esophagus. Because if it keeps doing that reflux, it's going to burn the esophagus and create more problems. These things, this Nissen fundoplication, is also done when we put in gastrostomy tubes. Because as the kid gets older, we're going to get bigger boluses of fluid. We don't want that coming up their esophagus and vomiting, right? Well, this procedure holds it in the stomach so they get their food. Hepatitis, there's how many types of hepatitis are there? A, B, C, D, E, F, G, H. I mean, there's a lot of them, and they're all due to many different things. But hepatitis in general How are you as a nurse going to treat them? That's what our issue is. Now, hepatitis A, wash your hands, right? I mean, but any of them, I'm washing my hands. But what diet are we going to give them? Well, hepatitis is the liver. The liver secretes bile, which digests fat, right? So you're not digesting fat. So these children, you should have them on a low-fat diet because fat in the diet causes bloating and gas, and it's painful, right? But these kids still need nutrition. So they give high protein, high carbohydrates, because they no fat, which is the highest calorie per gram, right? I believe the number is 9 calories per gram of food, nutrition, and it's 4 and 4 for carbohydrates and protein. So that's a lot of calories you're not giving it. So high protein, high carbohydrates, low fat, and milk, fish, fruits, vegetables, and milk. Dairy is good for them. Don't think because it has some fat in it, we still can give some milk because they do need it. Another thing that we talk about with diet and what should we give is celiac disease. Wheat, barley, oats, and rye should not be given. Remember, anything that's breaded could have one of those there. So none of those, no chicken nuggets for these children and no macaroni and cheese. I mean, there's so many other choices today that we can give them. You know, years ago, we didn't have all of these labels that said gluten-free. Today we do. Even go to the bakery, it's gluten-free, gluten-free. And it's actually not a bad choice for many people, just in general. Anyway, what do you eat with celiac disease? Let's have an omelet with cheese on it. Let's have a glass of milk, a bowl of ice cream, an orange and a banana, and a bowl of broccoli, right? I mean, all of those things are great. And I'm sure we can get some kids to get something that they do like. But wheat, barley, oats, or rye, these kids, they go into severe pain. I mean, bent over. This is the bladder exstrophy. Remember I talked about bladder exstrophy, and this is another one that's born outside of the body at birth. Our priority is to maintain tissue integrity and prevent infection. Again, they're going to need some normal saline at birth to put it on a dressing and get it covered to prevent exposure to the air. Now, that bladder still works normally. It still goes down through the urethra, but it's just sitting up there. So we need to prevent infection and keep the skin integrity. And sometimes they'll even put like a little bit of ointment like around it, you know, to keep it moist down there too. They do fix this pretty quickly because of the irritation and the chances of infection. Sometimes it's right after birth, sometimes it's within 2 to 3 months. Meckel diverticulum. This is small bowel. There's a little piece of tissue which has a big blood vessel in it that's inside the small intestines, and it rips. And it causes what we call painless rectal bleeding. You might have a little bit of abdominal pain and cramping, but it's not like anything significant. And that's right at the belly button, okay? They go in, they do surgery, they remove it, and these kids do well. Hirschsprungs. Remember, this is the one that we see at birth with no stool because the intestines are aganglionic. It's what we call no nerves, aganglion. A ganglion is a nerve. So it stretches. Peristalsis, no, because there's no nerves to make those muscles stimulate. So everything sits there and stretches, 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 stretches. And what happens is they can't get it down, you know, to the outside, to the rectum. So what happens is these children might have a little bit of, ever take frosting and put it in one of those little things and squeeze it out onto a cake to do like write a something or make flowers, that little squirt of ribbon. Well, that's what you might see in Hirschsprung's disease. What do they do with Hirschsprung's disease? Well, the other name is called megacolon. It's a big colon, right? It is a bowel obstruction, so you're going to be watching for that also. This child's going to have surgery after we do the biopsy and we find out there's no nerves. And this kid's going to have a colostomy. Usually within the first year, they can close that colostomy. So a colostomy is made, and then later on, depending on what's left there, etc., then they will close it, as I said, within the year. Another thing, tracheoesophageal fistula, or a TEF, or esophageal atresia. Both of these have one thing in common. They both put mucus from the mouth, saliva, when the baby swallows, it goes directly into their lungs and causes choking and gagging. If you feed them milk, it goes directly into their lungs, and now you have aspiration pneumonia. Even just regular saliva causes aspiration pneumonia. So what we do for these children, at birth, these kids could be coughing and spitting and turning blue. Now we know it's going directly into the lungs, okay? So these children, put them in a whatever, with their head of their bed elevated, whether it's a warmer or an isolette. Make sure there's suction at bedside, and nothing to eat or drink. We will start an IV, and because they're still swallowing saliva, we're going to put them on antibiotics because they are going to have little mini aspiration pneumonias, okay? The parents can hold these kids, it's not a problem. This kid's going to need a pacifier. Remember, they can't eat or drink. They need to self-soothe. This kid needs that pacifier because they're not getting nutrition in their mouth. And these kids usually are normal kids, and they usually will fix them up, and these kids do well. Nephrotic syndrome has nothing to do with renal failure. Nephrotic syndrome, this is not renal failure. It's the kidneys say, protein, I don't like you, I'm going to get rid of you. In a nutshell, it's all about protein. So in the blood, all the protein or the albumin is being urinated out. So you're going to see urine that looks like beer that's been foaming. I mean, that's how foamy this urine is. Massive proteinuria. In the blood, there's no albumin. So you got to be really careful with medication delivery because there's going to be a lot of free medication going around. It's just, there's no protein or albumin for it to hop on. So you need lower doses. There's also hyperlipidemia. And because the body doesn't like to be in a hypotonic state, the fluid from inside the vessels are going to go interstitially. These kids are going to have edema everywhere. Usually, you'll see it in their face, around their eyes. You're going to see their tongues and their cheeks inside swollen. That's why the kids don't like to eat, because it hurts to eat. So, again, we're talking about the kidneys. We're talking about a fluid problem, right? So what are we going to do? Priority, daily weights, intake, output. And because these children are retaining fluid, salt restriction and fluid restrictions for life. Okay? These kids are actually treated with steroids also, but it's lifelong. It's something that doesn't go away. Acute glomerulonephritis. The kidneys are infected because we had a strep infection that we didn't treat or was not completely treated. So acute glomerulonephritis and rheumatic fever, same. It's because of a strep throat. I think you're understanding why we need to tell parents to treat a strep throat completely to finish the antibiotics, right? These are two serious things. Now, acute glomerulonephritis, you're going to see stop urinating. Well, you stop urinating, what's going to happen? You're going to swell. Your blood pressure is going to go up. Of course, circulatory congestion because you're swollen everywhere. And then it goes to hematuria, proteinuria. So these are things that the symptoms you see. Now, how do we treat it? Well, once we determined that this child's had this strep throat that wasn't treated, or they didn't finish the antibiotics, or didn't go back and get checked when they were done, we're going to put this child on the antibiotics. That's going to help. But during that time, again, it's fluid. daily weights, intake, output. And because, the kidneys are in the peritoneal area, we're going to be doing abdominal girth. And again, low sodium fluid restrictions, fluid restrictions. And remember, these kids are really susceptible to infections, just like you would see with nephrotic syndrome. So again, good hand washing. There's a beautiful picture again that tells you all the things that you see. But again, all of these things will come back to normal usually. Okay, so treat these kids by antibiotics and intake output. And we're going to be watching fluids and salt and daily weights. Now, this is a beautiful picture of hypospadias, epispadias. I didn't have this one in your PowerPoints. So some students wanted to do this procedure under locals. Now, this is an older person, but you can absolutely see they fillet the penis. What this is there is a opening, whether underneath the penis or is on top of the penis, called hypospadias, or on top epispadias, okay? So the opening doesn't come out to the end of the penis to the urethra. So they usually do this before they're potty trained. This picture is an older person for whatever reason. I don't know why, but I love the picture, so I took it, okay? Now, how do they treat this child? Well, they use the foreskin. So these kids cannot be circumcised, and they use that for the plastic closure. They put some sort of catheter in there to keep the lumen open, and in children is a little plastic tube like we would use for female straight calves or kids straight calf, that little plastic tube thing. That's what they use. And it's in there for like up to 2 weeks. We don't do anything with that catheter. We just keep the catheter inside the diaper, okay? Because it's going to leak urine, okay? So hypoepispadias, the big thing in children is that we have to keep the foreskin. This might be some concerns in some religions, like the Jewish religion. Chronic kidney disease. This is, a progressive loss of kidney function, and the kidney doesn't do what it's supposed to do. We know it has to do with a lot, with certain minerals. Calcium, potassium are the big things it regulates. Also, it's the red blood cells. So if we know these are the concerns that we're worried about, and those vitamins and minerals for both and growth development, there's some things we need to make sure that we replace and watch, okay? So we're going to be giving erythropoietin. We're going to be given that so that the body can stimulate its own red blood cells and decrease the amount of transfusions. We're also going to be given vitamins D and calcium because we don't want to have osteodystrophy. We don't want the bones to be shorter or crooked or malformed on these children. We want them to be as tall as they can. So those are things with chronic kidney disease we will look for. And of course, always at rest. Peritoneal dialysis. This is a great alternative. And as I said, these kids, adults are doing this now also instead of going directly into the hemodialysis. Infants cannot be on hemodialysis because of the blood flow. The blood flow in and out is too high, and their vessels in their brains are very fragile, so it will burst them. So we don't use hemodialysis, we only use peritoneal. And peritoneal dialysis, the great thing, it could be done at home, it's done at night. Parents do it. I saw one parent, Willie's parent, did an amazing job for 3 years till he got a kidney transplant, never an infection. Very important that we monitor those bellies, those peritoneal cavity, which is your kidney, making sure it doesn't get an infection. So what would we be looking for in case there was an infection? Well, if there is a change in color, if it becomes cloudy, or if we see redness on the abdomen or around the tube, a change, or a fever in this kid, notify that doctor immediately. That's number one. Notify the doctor. What's he going to do? He's going to take no chance. He's going to order antibiotics now. A renal biopsy, something that we have to do either to look if the infections or look for tumors, etc. These are things that we'll be looking at. There are very similar instructions than they are with cardiac caths, okay? So NPO before, according to the child's age, of course, they will be getting some sort of pre-medication. And we always will monitor when they come back, the vital signs for sure. But we're going to do the same thing we do for cardiac cath. Check that dressing for leaking. We've gone into the kidney. It could leak urine. We've also could have gone through a blood vessel. It could be bleeding. Also remember the belly can get full of also urine. So look at that belly for a belly pain and tenderness. Bed rest 24 hours. So check the dressing, bed rest 24 hours. And again, we've touched the kidney. What else do we have to do? Intake, output, okay? Transplants, my little Willie got his transplant. I was so excited. One of the biggest concerns is rejection. Biggest cause of transplant failure. These kids will be on immunosuppressant therapy for life, and also that erythropoietin injections to help the kidneys produce their red blood cells. So when you see rejection, you're going to see all different things, but the fever and decrease in urine output are the two big things. So if you want to do some sort of nursing diagnosis, risk for infection related to immunocompromised state and post-transplant medications, right? That would be a great type of nursing diagnosis. Now, fractures. Most common thing kids does is the wrist. They fall down, puts their wrist out, right? We know that some could be open. If you get a fracture, whether it's like that little finger or that whole elbow, those children need IV antibiotics. That is an open or compound fracture. Your risk of osteomyelitis and infection are huge, okay? The simple or closed is the ones that are inside that never come through. And then we have complicated and comminuted, which are either can damage organs or it's all different pieces there. Remember, any infant who's coming in with fractures always needs to be looked at carefully because infants' bones are soft. It really takes a lot to fracture their bone, okay? And those are all the types, another picture for you to look at. Remember, in any fracture that we look at, we're going to do the 5 Ps, pain, pulselessness, pallor, paresthesia, paralysis, and we need to be teaching these things to the child and to the parent to make sure that the blood is flowing to where it should. Cast care, should be elevated for the first day. We want to keep those fingers moving. Tylenol is good enough for that. They should be not really doing a lot of crazy things for the first couple days. Let that arm heal a little bit. Really important. It's hard to hold some kids down, but we have to. Types of traction, there's skeletal, skin, cervical. I think the one that we use the most is this top one called Buck's traction. It's a skin traction and it pulls the lower leg and it's for that fractured femur. So it puts those bones together. And what that does, it prevents deformities that could occur, but it also reduces muscle spasm. Those femurs, when it break, has sharp edges. So we want to put those edges of those bones back together. And how do we treat these sort of tractions? Well, keep that the weights and those ropes hanging freely 24 hours a day. We're never going to take it off because it's going to dislodge that bone position there, okay? We need to document that every day, how much weight is on there, all right? And then we're always going to be neurovascular signs. Fractured femurs, before we even get them to traction, those little pieces of sharp edges of bone has created a lot of damage and swelling, and it could occlude circulation. So making sure, checking for those pulses, etc. These children should be having those fluid intake. They have that overhead trapeze they can move around with, and again, free hanging weights. Now, hip dysplasia. Children are born with hip dysplasia. Remember, infants can heal cast in 2 to 3 weeks. They're amazing. So what we'll do is put them in a Pavlik harness for abduction of the hip. Remember that word, abduction. It holds those hips the way that it should be, trying to force those hip sockets back into those bones into the hip socket so that it's going to heal correctly. If it doesn't heal that way, you could do spinal casts, and sometimes they have to do surgeries to open up the tendons to stop that pressure from holding it away, so we can put them in there. But usually that Pavlik harness works like that. Scoliosis. Scoliosis is an S-shaped curvature. We see a lot of that during that pre-adolescent growth spurt. And it's, again, the S-shaped thing that goes on. Now, if you see a curvature, you see it more than 45 degrees, this one cannot be put in a brace. This child's going to need surgery. And it's because the way that spine curves, it is taking one of the lung places, it's taking up space. So the lung can't expand the way it should. So we need to get that as straight as we can to allow respirations for breathing, okay? Now, if it's less than that, we'll just put them in a brace, and we will be teaching them these exercises that must be done. Now, problem with the brace, these children are pre-adolescent. They're in that body image area, right? They're into my identity and body image. So again, one of the good diagnoses there is disturbed body image. So, having that child having really neat colored type of braces might help them, or loose clothing to put over it so they don't see it. But again, being aware of that with this age children, they can do really well. They put the brace on, they do surgery, 23 hours a day it is on. They take it off for 1 hour for showering and to wash the inside of their braces. Osteomyelitis. I mean, see that arm, how it got red all the way up? You could see toes and feet and hands and fingers. I see a lot on toes, believe it or not, osteomyelitis. Kids like to walk around with no shoes on, just like me, right? Well, what happens is all of a sudden the toe will going to get red and swollen and painful. And then the kid's going to start with the fever, the chills, the nausea, and your white count's going to be really high. How do we treat this? Well, most of all, this infection is usually staphylococcus, right? So it needs to be treated with IV antibiotics. Remember, these IV antibiotics for staph are usually aminoglycosides, so they're dangerous. So making sure that they do get the proper lab results. Usually they'll put this child on more of a complete bed rest, keeping that whatever it is, the limb, the toe, whatever, immobile, take care of pain. They're on long-term IV antibiotics. It could be couple months. So it depends on the child. Now, remember nutrition. This child, because we're talking about bones, and bones are connected to muscles, we're worried about making sure they have enough high protein and carbs for these children so that they get the nutrition that they need and the protein they need for healing, okay? And these kids usually going to be at home. So making sure that these kids do have something they can do to keep their minds occupied. Sometimes osteomyelitis has led to things like amputations. So if we don't treat them good, it can happen, just to let you know. Now, systemic lupus, autoimmune, and the body attacks all the organs, right? Here's all of the things: the macular rash, the discoid rash, photosensitivity, oral nasal ulcers, arthritis, et cetera, et cetera. These children here usually present with the headache, fatigues, and this rash. They're usually girls in that late childhood area, early adolescence. Big thing about lupus and me, who lives in South Florida, is sun is actually one of the things that can trigger, flares on these children. So making sure that they have sunscreen, make sure that they be very careful of exposure to sun. What they'll do is these children will get steroids and prophylactic antibiotics for any sort of procedures. These children should also wear a medical alert badge, because the rashes on their faces are all different. You can't say one is the same as the other. They're different. And then JIA, autoimmune body attacks the organs. Now with JIA, you're going to see joint problems. So you're going to see that loss of motion, or really, especially in the morning, that morning stiffness, shuffling when they walk because their joints are so stiff. You're going to see some of those, bony enlargements, joint disfigureness. And the one thing that we don't think about is this uveitis. And uveitis can lead to vision loss. These children need to be checked their eyes for this redness that goes there. And sometimes you get this little tiny little chin because the temporomandibular joint is also one that could be affected. And I mean, those who know me, I have rheumatoid arthritis. It affects my voice on a regular basis. I didn't know the voice box has some sort of joint there. And then Guillain-Barré. Guillain-Barré is usually in older people, but young kids can get it. And what we'll see is all of a sudden the kid is going to have trouble walking and will start falling and have leg pain. Usually there was some sort of upper respiratory a couple weeks earlier. It is viral. It's what we call ascending, starts with the feet and works upwards. So you'll see the problem with the toes and the weakness, waddling, and then it gets to being incontinent, constipated, and then it's going to hit the diaphragm. Remember, there's a phrenic nerve because this attacks all the nerves, okay? It causes numbness, etc. So when it attacks the phrenic nerve, this child stops breathing. The child's going to have to be ventilated, okay? How do we treat once we know? Well, we're going to treat this child with intravenous immunoglobulins, okay? Sometimes steroids, but usually it's the IVIG. We're going to be monitoring their respiratory status as number one. Even if they're not intubated yet, because that's when all of a sudden they could go apneic, and now you must breathe for them. They must be intubated, okay? And then all of a sudden the ventilator, all of a sudden you'll see the child start breathing over the set amount of rate of respirations that are delivered. All of a sudden you're going to see the kid start breathing. Then it goes descending from the lungs down. During this, you're going to have your dosage calculations similar. You're going to see heparin, you're going to see insulin. You're going to be seeing your same milligrams to micrograms. So I know you guys can do it. I know there's a lot of information. Thank you for being patient with me. You all have a great day. Any
Thank
questions?
you.
You're very welcome.
you.